Dr. S. Jayapriya. I am a junior resident at Fortis Hospital Cunningham Road. Today I have with me Dr. Mangesh, who is Additional Director and Senior Consultant in the Department of Medical Oncology and Haematology, Fortis Hospital Cunningham Road. Along with him, we have Dr. Shruthi, who is a Senior Consultant in the same Department of Oncology in Fortis Hospital Cunningham Road, Bangalore. So my first question is to Dr. Shruthi. How common is pancreatic cancer and what are the causes of pancreatic cancer?
Pancreatic cancer is not a very common disease. That's why the awareness about pancreatic cancer is also less among the general population. Coming to the causes of pancreatic cancer, the most common attributable cause could be smoking. About 20 to 30% of the pancreatic cancers are caused by just smoking or any form of tobacco use, either in the form of chewable tobacco. And next common cause would be any genetic conditions or hereditary conditions. Even if there is a family history of pancreatic cancer, either one or two relatives having pancreatic cancer, that could increase the risk of pancreatic cancer in a patient, as well as some genetic conditions, that is genetic mutations, especially one which is related to the breast cancer also, called the BRCA1 or 2 gene. They also increase the risk of pancreatic cancer, and of course there are many other genetic mutations that can increase the risk of pancreatic cancer. Coming to other less common causes would be very high intake of alcohol, also obesity. Being overweight or obese is a risk factor for pancreatic cancer, and some medical conditions like having chronic pancreatitis, again which is related sometimes to alcohol intake, or hereditary pancreatitis. All these can increase the risk of a patient developing pancreatic cancer.
So Dr. Mangesh, how does a patient with pancreatic cancer present at a clinic?
So the way a patient with pancreatic cancer presents is also dependent on what is the causative factor for pancreatic cancer. So a lot of patients who have alcohol or tobacco, a lot of these patients develop pancreatitis. Alcoholic pancreatitis is something which is commonly seen by gastroenterologists and surgeons alike, and they tend to develop with weight loss, a vague abdominal discomfort all the time, accentuated once they eat their food. Sometimes they get up in the night with pain. They tend to have this always that feeling of indigestion. Then they also sometimes can present with really severe pain also, which mimics pancreatitis, but when you do a scan you will find out that there is a tumor. Then some of the times they go to a physician and they see that there is jaundice, a lot of jaundice, and this jaundice brings them to undergo a scan or something, after which they will be found out to have pancreatitis. So weight loss, vague abdominal pain, indigestion, jaundice, these are some of the very important or the most common presenting features. Sometimes they can come with fever, sometimes they can come up with this diarrhea, some of those vague symptoms, bloating, all those are very vague symptoms. So these are some of the commonest symptoms that you'll see.
So doctor, once you suspect pancreatic cancer in a patient, how do you further evaluate it?
Yeah, so when we have a patient with so-called symptoms of something not happening well in the abdomen, most clinicians will ask for a complete blood evaluation, a CBC, LFT, RFT, basically liver function, kidney function. We look at other factors like electrolytes to find out what is the cause of abdominal pain. After that, we go for the first and still the most important test, that is ultrasound of the abdomen pelvis. After that, once we know that this patient has got some suspicious tumor or some sort of a lesion in the pancreas, then we can go ahead and do the tumor markers. The tumor markers that we commonly do is called the CA19.9, CA19.9 we call it in our routine practice. It can be elevated in up to 85% of the pancreatic cancer patients. And now when you have a patient who's got a lesion in the ultrasound abdomen and also CA19.9 is elevated, most of us will then proceed to do a CT scan of the abdomen pelvis, or sometimes a whole body CT scan, we call it neck, thorax, abdomen, pelvis. And in some of the cities or a well equipped center, we will go ahead and do even a PET CT scan. Sometimes the jaundice is being evaluated by the medical gastroenterologist. They may tend to do an MRI or even an MRCP, and then they find that there is a very small tumor in the pancreas which will be detected, and then they will be referring it to the oncology team for further workup and treatment.
So, Dr. Shruthi, what are the important points that you consider before starting treatment for a patient who's diagnosed with pancreatic cancer?
So treatment of pancreatic cancer is little difficult compared to other cancers. The two important factors that we consider are patient factors and the tumor factors. So once the patient has been diagnosed, we always keep into consideration the patient, how the patient is when they present to us. So the age of the patient, that is very important, because cancers as such, and especially pancreatic cancer, is more of a disease of an old age. So the patients who present to us are slightly older. So the age is a very important factor we take into consideration before suggesting a treatment. And second would be the nutritional status of the patient. How is the patient, whether patient has lost a lot of weight and nutritionally not fit for the treatment, or whether we need to build up the nutrition before we can start the treatment. All this needs to be taken into consideration. And also the bilirubin levels, that is in the liver function test, because there is jaundice in most of the patients. Depending on the bilirubin levels, if the bilirubin is too high, then it might make the treatment a little difficult to start with. So in such cases, we might have to undergo an ERCP and stenting to relieve that obstruction, so that then we can proceed with the treatment of patient. Then comes the tumor factors. So as Dr. Mangesh already mentioned, that we'll be having a CT scan or a PET CT done for the evaluation of a pancreatic cancer. And so the tumor, when it is detected, the most important thing in pancreatic cancer is the treatment is slightly difficult because of the proper positioning of the pancreas itself in the first place. Pancreas is something that lies behind the stomach in front of the major blood vessels. So when it comes to any tumor in the pancreas, they might be involving they might be very close to the blood vessels and the critical structures, the blood vessels which supply the intestine or to the liver. So all this needs to be taken into consideration. So what is the extent of the disease? What is the stage of the disease? All this will be taken into consideration. And in Fortis here, we always go for a multidisciplinary team meeting. So any patient, we cannot give one size fits all treatment in terms of cancer. So each patient needs an individualized approach depending on the patient factors, as I mentioned, age, the nutritional status and other conditions, how is the performance status of the patient, and as well as the tumor characteristics. So based on all this, we will be having a multidisciplinary team meeting where the surgical oncologist, medical oncologist, radiation oncologist, the anesthetist, radiologist, pathologist, all of us are involved. We discuss each and every patient, and then we take a decision based on what would be best treatment for that particular patient. So based on this, then we will give the patient the options, the best line of treatment for the patient, and then the patient can take an informed decision.
So, Dr. Mangesh, so how do you treat a patient with pancreatic cancer?
So as Dr. Shruthi pointed out, with pancreatic cancer, we have to be extremely careful at the beginning itself, because there are a lot of centers where the patient goes directly to a medical oncologist or a surgical oncologist. There is no multidisciplinary discussion that occurs, and patient either directly goes for surgery or directly goes for chemo, which sometimes may not be the right idea. So we have to have a discussion, and I believe that with the multidisciplinary discussion, we can save the cost of treatment for the patient. We can bring out the best possible outcomes for this patient, for the current stage and patient's profile. And last but not the least, we will be able to give a lot of happiness and satisfaction to the patient, that there is a huge team behind who's trying to make sure that he or she is being taken care of. Remember, pancreatic cancer is one of the commonest cancers. It is one of the top 10 commonest cancers that we know of, but it is one of the most difficult to cure cancers, and we have to somehow enable that the patient undergoes a successful surgery by the surgical oncologist. That is very important. So if there are 100 patients with pancreatic cancer cured, 99 or 100 of them will have to undergo a successful, what we call as a total resection of the tumor. That is the first goal of a pancreatic cancer treatment protocol. Then where do I come into the picture? A medical oncologist comes into the picture for what we call as ancillary, supportive and enabling protocol. How do I do that? For example, if Dr. Shruthi believes that she requires the tumor to be slightly smaller than what it is currently, involving the blood vessels, which probably may make it difficult for us to completely resect, in those situations, I will come into the picture, give what is called as neoadjuvant treatment. That means treatment before the surgery. And if the tumor size is say 5 or 6 centimeter, bring it down to maybe 3 centimeters, 2 centimeters and ideally even 1 centimeter. Make sure that the tumor is away from the artery so that she can remove it without much complications during the surgery. So I am doing what is called as downstaging of the tumor or reducing the size of the tumor. I am doing what is called as a better surgical result. I am enabling that better surgical result. Last but not the least, please remember, all cancers are systemic disease. Systemic means if you have the tumor originating from the pancreas, there are some tumor cells which could have escaped in the blood to other organs in the body. So by giving neoadjuvant treatment, I will be enabling the death of all those spreading tumor cells which are small in number initially and destroy them, so that after the surgery and you have removed the visible tumor, the invisible tumor is also destroyed, so that the highest chance of cure can be given. So there are a few other strategies that some of us employ. Sometimes, I mean, there are some institutions, and we sometimes also think about it, is to also give radiation along with the neoadjuvant chemotherapy. It is not something that is followed much today, but in certain situations we can employ that as well. Then Dr. Shruthi was talking about genetic mutations. There are a lot of patients who are not smokers, not alcoholics, do not have a bad cholesterol profile, but still they develop pancreatitis or even pancreatic cancer. And some of those mutations are BRCA1, BRCA2 mutations. And sometimes what we do is we give targeted therapy along with the neoadjuvant chemotherapy, so that the results of the neoadjuvant chemotherapy is increased to a great degree, and this helps the patient to undergo a successful surgery. Sometimes you also employ immunotherapy. All of you would have heard of immunotherapy. Immunotherapy can also be used in pancreatic cancer. Sometimes we use immunotherapy, targeted therapy and chemotherapy in various combinations depending on the patient's profile. And a lot of pancreatic cancer patients come in the elderly age. So these patients may not be able to tolerate the full dose of chemotherapy. In those, reducing the dose of chemotherapy and giving targeted therapy or immunotherapy along with that, we call it as a synergistic therapy, helps to reduce the size of the tumor. Once the size of tumor is reduced and I get a green signal from the surgical oncology team, then the patient can undergo the surgery, and this will ensure that the patient has the highest chance of cure.
So Dr. Mangesh, you mentioned that a lot of patients are the elderly patients. So could you please tell us on how do you treat elderly patients with pancreatic cancer?
So as I told you, elderly patients are difficult to manage. Now in pancreatic cancer, there are three major stages that we look at. One is the localized stage, that means the tumor is inside the pancreas, there is no extension at all outside the pancreas. In the stage 2, we have those what we call as locally advanced, that means they may be touching on the nearby blood vessels, may be touching on the nearby structures. They are difficult to remove because they may be attached to them and you can't rip them off. Once you rip them off, there will be widespread bleeding inside the abdominal cavity. And then you have those patients with metastatic disease, that means the disease has already spread to other organs. In those cases, cure is extremely minimal, less than 5% in my opinion. So when we have these patients with pancreatic cancer who are elderly, and we see them very commonly in our practice, in those patients what we do is we first do a complete geriatric assessment. We make sure that they are assessed by the geriatric specialist. I have trained a bit in managing the geriatric patient, so I have my own scoring ways where I can understand whether this patient is physiologically the same age, physiologically younger or physiologically even older. So once we get those kind of patients, we then have a tumor board discussion, because again, like she said, one size does not fit all the pancreatic patients. We have to individualize it, personalize it, and make sure that the best protocol can be given. So if we have those patients with localized, we usually employ the latest surgical techniques. Dr. Shruthi will speak after me, And if they are locally advanced, I told you that we try to reduce the dose of chemotherapy and then we go for target therapy or immunotherapy. Now, metastatic pancreatic disease can be seen in both young and elderly. In those patients, our job is to basically extend the life of the patient, reduce the symptom of the patient. They may be having a lot of pain which may not be able to withstand. They may be also having weight loss which makes it difficult for them to live long. So our job is primarily to reduce the symptoms, improve the quality of life and extend the life of the patient as long as possible. And we have a lot of ways to do that. We give low dose chemotherapy for these patients, we give targeted therapy for these patients for long, and we also give immunotherapy for these patients. Remember, earlier, maybe 10 years ago, pancreatic cancer patients who are either unresectable or stage 4 would not live beyond 1 year. But now we have a lot of latest genetic technologies, we have latest therapeutic modalities by which we have patients who are living beyond 3 or 4 years with the best of care. So please make sure you don't give up if the patient is elderly, don't give up if the patient has stage 4 disease, and don't give up if the patient does not is not able to undergo surgery. So regarding the localized surgery, I think Dr. Shruthi can tell.
So to talk about pancreatic cancer surgery, as Dr. Mangesh already mentioned, surgery is the best form of cure for pancreatic cancer, and that can be done only if it is detected in the early stage. So in the early stage, not only for early stage, for any cancers, the most important surgery would be a radical surgery. In pancreatic cancer, it would depend on the site of the tumor, where it is. So pancreas has a head, body and tail. So if the pancreatic cancer is in the head of the pancreas, then we would go for something called a Whipple surgery. That is a radical surgery which involves removal of the pancreas along with the duodenum and a part of the stomach and the small intestine, and along with the surrounding lymph nodes. This involves the complete surgery, and this is a little complex surgery, as I told you already, because of the position of the pancreas, which is lying right in front of the major blood vessels. So in doing a Whipple surgery might take a long duration, somewhere even it might range between 4 to 8 hours. But then now we have so much of advancements in anesthesia techniques, and the ICU team here, we have a very good support from them. So we've been able to do this surgery, even though it is a complex surgery, we have been able to do this surgery even in the elderly patients, even for patients who are about 80 years of age with some comorbidities like cardiac conditions or diabetes or hypertension. And for those patients who have a tumor in the body or the tail of the pancreas, the surgery is little bit much simpler than the Whipple surgery. That would involve just removing of the tail of the pancreas, with probably sometimes might require the removal of the spleen as well. So surgical part, when we consider, first of course we always look into the fitness of the patient, whether the patient will be able to tolerate the surgery, and also the tumor characteristics, whether it is not adherent to any of the major vessels, and we can go ahead and remove it, giving a complete negative margin. So in case we are not able to achieve this, or we need some time to build up the nutrition of the patient, then I would take the help of Dr. Mangesh to consider for a neoadjuvant chemotherapy. If this is feasible, or if post neoadjuvant therapy the tumor has shrunk and the operability is assessed again, and then if we feel it's operable, then we go ahead and do the surgery.
Dr. Shruthi, could you please tell us what is the cure rate for pancreatic cancer?
Cure rate for pancreatic cancer again depends on the stage of the disease. So when patients present to us at stage 1, which is not very commonly seen in our country, especially because there is not much awareness about it, and as already mentioned, the symptoms of pancreatic cancer are somewhat vague. They do not correlate it with pancreatic cancer immediately. So again that depends, the cure rates will depend on that. So patient, if they present to us in stage 1, and if a successful surgery is done, post the surgery, sometimes depending on the final report of the surgery, the patient might require an adjuvant therapy or might not require any further treatment. If they present in stage 1, there are very high chances that we'll be able to achieve a cure for a 5-year survival rate of about even 80 to 90%. But as the stage keeps on increasing, the 5-year survival comes down. So on an average, if we say, we can say that in pancreatic cancer we have a 5-year survival of somewhere between 30 to 50%.
So Dr. Mangesh, is there any way one can prevent pancreatic cancer or detect it earlier?
So we can categorize into preventable cancer and the probably screenable cancer. So I will tell you how this works. Preventable means, for example, if you consider an individual not to have any of the familial genetic mutations, right? So like Dr. Shruthi said, BRCA1, BRCA2, some other mutations are there. There are also CDH1 mutations, some other mutations are there. If those mutations are there, even if the patient does not have alcohol, does not smoke, or does not have obesity, the patient has a high risk of getting it. So the way to prevent cancers, or make sure you detect cancers in them in the earlier stages, first is you have to make them aware that if you have these genetic mutations, these are the cancers you can get. That is very important, and we call it as genetic counseling. Those patients whom we have a situation where we are trying to tell them that they can undergo screening tests regularly after the age of 40, they can probably have routine scans done regularly. If they have abdominal pain, they can probably go earnestly to the doctor without waiting and taking over the counter medications. And if there are patients who are alcoholics or smokers, they should be discouraged from continuing their abuse. They should concentrate on losing weight, have a good diet, and those who have very high cholesterol levels, even high triglycerides can cause pancreatitis. Those patients should also be recommended to make sure that the cholesterol levels or triglyceride levels are normalized. And those people who have already had pancreatitis due to any cause, they should be warned that they should be in close follow-up with the doctor, because any time pancreatic cancer can develop, and that is something that they need to remember very clearly. And also I also would like to tell a lot of doctors, especially the specialists or even those who have done graduation and are family physicians, they should also have a high index of suspicion for pancreatic cancer, especially when the abdominal pain is very common. It's occurring despite multiple medications. So a lot of times you would be surprised to know that in our country, family doctors are hesitating to even do an ultrasound scan. So we need to make sure that those things are done. So prevention means to be able to prevent the so-called preventable factors, and those who have a familial history should be aware that they can get this cancer.